everybody. Welcome back. It is another beautiful sunny day in Longview, Washington on October. False. It is raining very hard. And our favorite rainy day topic is cholesterol. So that's what we're going to talk about today. So we're going to take some time to address lipids or cholesterol. And I think everybody is familiar with this term, but we just really want to dive into the standard lipid panel that we do for most of our patients at their annual visits, and then go a little bit in beyond that to more testing that can be done. And we just emphasize here, cholesterol is important, absolutely, but it's just one piece of the puzzle, right? Like it's not like you can say, oh, my cholesterol's really great, so I don't have to worry about my blood pressure or my weight or the fact that I smoke, right? It's just one piece. It's the whole puzzle. So that's what we're going to talk about today. And we have my brother Scotty, the in-house cardiologist at Kirkpatrick Family Care. So Scotty, why don't you just tell us a little bit about cholesterol basics? Like, what is it? Why is it important?
Yeah, so cholesterol, I think, is sort of a lipid molecule or like a fatty molecule that we have, every cell in our body has it, and it also is in our bloodstream as well. And um, in our bloodstream, as you guys know from going back to probably elementary school, water and oil don't mix. And so water and fatty substances like cholesterol don't mix, so they have to be packaged in these particles or these lipoproteins. And so we have lipoproteins in our body that carry cholesterol. And for certain densities of those, the most common one being the low density lipoprotein, it's been shown numerous studies over and over and over that the higher the amount of the cholesterol contained by those particles is, the higher risk of heart attacks and strokes, because it can get into the walls of our arteries and cause plaque. And when that plaque is there, not only can it slowly progress over time and gradually reduce blood flow to our organs, but can also more acutely rupture. And when the plaque ruptures, that's a very big event that can cause a blockage, or at least a new severe narrowing in our blood flow to things like our heart or our brain. And when that happens, that is a stroke. So as you alluded to, it's an important metric. And I think we also have to have the important discussion that it's not the only metric. And so sometimes I think cardiologists and doctors get too focused on cholesterol, and forget all this other stuff. But on the flip side, there's also plenty of people who would say, oh, well, my blood pressure is good, or I don't have diabetes, I'm metabolic healthy, so I don't need to worry about my cholesterol. And while that's great that you have great blood pressure or great, metabolic health or whatever the thing is, it doesn't mean that we can ignore cholesterol. It's all of this stuff matters. You certainly might be at lower risk for having heart attacks and strokes, the more of those other things that you have under control. But that doesn't mean that you wouldn't be at even lower risk if you address your cholesterol. So I think there's two sides to that story, and we need to be honest. Everything matters, and that works both ways.
Yes. Okay. So the cholesterol is packaged into little proteins that can make plaque, and the plaque can rupture and cause heart attacks and strokes. How do we know that cholesterol actually is the thing doing that? And like, how do we have any data that shows that it really matters clinically?
Yeah, absolutely. First of all, we know that's what the plaque is made of because we can do autopsy studies and see the cholesterol and the lipid-rich containing plaques that are present, and that have ruptured to cause heart attacks. But when we look at clinically, I think what you're asking is, how do we know that lowering our cholesterol would actually do anything? And that's been shown in dozens and dozens of studies over and over and over, that the lower we drive our LDL cholesterol, all other things being equal, that's when we will see benefit. So if I look here and show you this. So are you able to see this, Christy?
Yep.
So, all right. So on this graphic here, what you see is this is looking at different clinical trials where these are randomized clinical trials where they split up two groups of a large amount of people, and half of you get a medication to lower your cholesterol, and the other half of you get a fake pill that's not lowering your cholesterol, but neither group knows which pill they're taking. So it's totally randomized, double blind. It's the highest quality of evidence we have. And as you can see in the blue line here, these are what we call secondary prevention trials. These are in people who have already had heart attacks. So they're at higher risk. They get put on medication to lower their cholesterol. And as we go from right to left, our cholesterol is getting lowered. And as we go from low to high, that's the risk of having a heart attack. And as you can see in the secondary prevention trial, as the cholesterol gets lowered, so too does our risk of having heart attacks. If we look at the red line, that's what's called primary prevention. These are people who have not yet had a heart attack, never had a heart attack, but they have been put on medication to lower their cholesterol, or in this case, placebo, trials where it's half of you getting a pill that lowers your cholesterol, half of you are getting a fake pill. Neither group knows which is which. And you can see there also, as we lower our cholesterol, lower risks of heart attacks. So even in people who have not had a heart attack, lowering our cholesterol still matters. And you can see here the event rate, or how often people are having heart attacks, and thus the event reduction is more strong in the people that have already had a heart attack, because if you've already had one heart attack, you're at higher risk for having a heart attack than just the average person. But we still, even in the people who have never had heart attacks, are seeing benefit of, we lower our cholesterol, all things equal, we lower our risk of future heart attacks.
And I imagine in these studies, like we have statistical methods for controlling for other things, right? So it's not like there would be we would try to control for other measures that would impact event rates, right? So like blood pressure and all that stuff.
Yeah, and that's why you randomize people. So in theory, if you take, let's just say 10,000 people that all have meet the same inclusion criteria, they're, within a certain age group, they have certain diseases, but they don't have other certain diseases. So it's kind of, you get this 10,000 roughly the same people, and then you split them into two groups totally randomly, that will even out everything. So as you look at all these trials, the blood pressure is about the same. The blood sugar is about the same. And then that's at the beginning of the study. And then they test these things during the study to see what is changing. And what happens is everything else basically stays the same. Cholesterol gets lowered, lower risk of heart attack.
Great. So we can really assess it as like an independent risk factor.
Absolutely.
So what's on the standard lipid panel that we check, and how is that helpful? How does it come up short?
Yeah, so the standard lipid panel has a couple things. It has your total cholesterol. It has your HDL, or high density lipoprotein cholesterol. It has your low density lipoprotein cholesterol, and it has triglycerides. The most important metric on that is the LDL. The LDL, as it's higher or lower, is very clearly tied to rates of heart attacks and strokes. HDL, I think there's a lot of people raise, oh, it's the good cholesterol.
Mhm.
There's no high quality evidence that says a certain HDL is necessarily protective, because HDLs can be high for good reasons and they can be high for bad reasons. HDL being low is a marker of poor metabolic health, so we want to have normal HDL, but it's not, we can't be in this false pretense or false assurance that, oh, my HDL is good, so my LDL doesn't matter. The LDL, which is the low density lipoprotein cholesterol, that is what's clearly tied to heart attacks and strokes. And so the standard lipid panel is a good test, but there are two other cholesterol tests that are honestly the best cholesterol tests that we should all be getting, and most people don't know about them. And this
Including
is
doctors. Yeah.
including many doctors. Yeah,
Yeah.
a lot of doctors know that. And this is not just me like saying that. Like, if you look at, the National Lipid Association, like, they're promoting like, hey, getting these two other blood tests are very important. And other organizations as well. So it's not just me. It's like really high quality evidence from big time organizations that are recommending this, but it's not implemented. And most people have never heard about the two tests that we're about to discuss, which are sort of cross-referencing the standard lipid panel to make sure that what they're telling us is really truly accurate, but also another test also provides more clinical context. So these two other tests that we're going to talk about are hugely, hugely, hugely important, and everyone should be getting them.
Right. And it's not like we're saying we should throw the standard lipid panel out. Like you said, LDL definitely has some clinical significance. Absolutely. And we want to pay attention to that. But we think there are other markers that give us more insight to overall cardiovascular risk and what we need to do to reduce that risk.
Absolutely. Yeah. And so, I mean, I think we can, we owe it to people to let them know about these things, because information is power. And once you get a really full context of where you're at, then you can make really informed decisions that meet your own personal goals and what you're willing to do to achieve those goals.
Yeah. All right. So what are these two? Hit us with it.
Yeah, so the two things are one's called an ApoB, and let me pull this up here if I can to try to show you guys this. So yeah, so as you can see here, off to the left is this is a low density lipoprotein. So what this is looking at is this is the cholesterol, the LDL on our standard lipid panel is looking at what is the cholesterol content within these particles that are called low density lipoproteins. That's what that's looking at. ApoB, though, I think is a better test. And actually, there's many other organizations that would agree with me that say it's a better test. And that's not looking at what's the concentration of cholesterol within this particle here. It's looking at how many particles are there. As you can see, every LDL particle has what's called an ApoB on it. It's a little marker that delineates, hey, this is a particle that could cause atherosclerosis, or that plaque to build up in our arteries. And the reason why this matters is that there are other particles in our blood other than LDL that can contribute to atherosclerosis. There's VLDL, there's IDL, there's LDL. So there's three things. Now, LDL most of the time is the predominant one, but in states like insulin resistance, which is becoming very common, all you have to do is listen to our metabolic health video to know about that. Our amount of LDL oftentimes is underestimated because of our insulin resistance. And it's when we get the ApoB, it shows, oh, hey, this is actually worse than I would have anticipated based on our standard lipid panel. And so that's one of the reasons why I think it's more important, is because insulin resistance is a very common thing, and we may be underestimating what our atherogenic lipoprotein burden is that can put us at risk for cardiovascular disease.
Okay. So that's ApoB. And this
Yeah,
is
and
the blood test, right?
it's a blood test. And so the way I think about it is as an analogy, that some people find helpful or not. Imagine you're going on the freeway. You're going to go on the freeway, and I tell you, hey, there's 100 people right now on the freeway. That you may think, gosh, there's 100 people right there, right in the freeway as I'm about to exit, or about to get on the freeway. That's a lot of people. There's probably going to be traffic, because most of the time 100 people would mean there's a lot of cars. And that's sort of analogous to, like, most of the time the LDL cholesterol is sort of telling the same story. How many people are on the road is similar to how much cholesterol is in the LDL particles. And most of the time that gives you an accurate story. But what is a better information is not how many people are on the road, but how many cars are on the road. Because if I tell you there's 100 people that are on the road, you don't know, is that there's 2 Greyhound buses and there's 50 people in one? There's no big deal. Like, who cares? There's not gonna be traffic. I'm good. Or is there 100 people in little, like, Chevy Sparks? And so that means there's 100 individual cars. That's a big difference. So what matters more is the amount of cars that are actually on the freeway. Similarly, what matters more is not how much cholesterol is within these particles, but how many particles are there carrying cholesterol, because it's the number of particles that are the potential bad actors. And when you know how many bad actors there are, that's when you know what your risk is more accurately. So
That's super helpful.
some people may not find that helpful or confusing. I apologize, but that's how I think about it. It's how many cars are on the road, not how many people are on the road. And that tells you what your risk is of traffic. Similarly, that would tell you what your risk is better of what's my cholesterol burden for my risk for heart disease.
So the LDL is sort of an indirect measure of those number of particles, and then the ApoB is really a direct measure of that.
Yeah, the LDL can sort of they tend to correlate,
Yeah.
but especially, everybody's different, but especially in things like insulin resistance, which is incredibly common, you're more likely to see discordance between the two, and then, be falsely, be basing your assessment on data that's a little off because you didn't get the true ApoB. ApoB is a very cheap blood test. Everyone should get it to check, where you're at. And if the ApoB and the LDL line up, great. That's awesome. Glad we checked. But sometimes you can be surprised, like, oh, wow, like I thought your LDL was pretty good, but no, the ApoB clearly tells us it's not. We need to be more aggressive. So that's where I think ApoB is really helpful and why I think everyone should get it checked.
Great. And what's the second one?
Yeah, so second one is lipoprotein little a, and I realize I'm sharing my screen here and you can see this. You see this little particle here. This is the apo little a lipoprotein, and this is on some of our cholesterol containing proteins. And what this little lipoprotein is it's basically an extra bad actor. So if we were to kind of continue on our analogy of the freeway, this would tell you like how many of these particles are, or how many of these cars are being driven by drunk drivers, or old people who shouldn't have a driver's license, or young people who just got their driver's license. You know, these cars maybe,
Drivers who are texting.
yeah, right. So it tells you like how many of these cars are should I really be worried about, you know? And similar with lipoprotein little a, this tells you how many of these particles have this extra lipoprotein on them that makes them more likely to be pro-inflammatory, prothrombotic, pro-atherosclerotic, all of which contribute to higher risk of cardiovascular disease. And so I think everyone should get their LP little a checked at least one time in their life. It's genetically determined, so it's not necessarily something that you're doing right or wrong. It's just you're born with this lipoprotein little a. And it allows us to say, hey, we know you have this thing that puts you at higher risk for cardiovascular disease. Now we know we might, if it's high, we need to take care of these other things.
Mm-hmm.
Right now, we currently don't have treatments for lipoprotein little a, but there's studies ongoing, so that may change. But so sometimes people will often say, well, then why do I need to know if there's no treatment for it? Well, if there is a treatment that gets developed and you know you have high lipoprotein little a, maybe you might qualify for something that could lower your risk and be helpful for you. But the second thing that I like to tell people about is, Christy, tell me, what's your favorite sport, just to use an analogy here?
Play basketball.
Basketball. Okay. So what if I told you, because being a good basketball team, there's multiple things that go into being a good basketball team, just like there's multiple things that go into lowering our risk or preventing heart attacks and strokes. So what if I just told you, hey, no matter what, your rebounding on your team is just going to suck. It's going to be terrible. And there's nothing you can do about it. Nothing. And your rebounding is going to be awful. That obviously is important. Rebounding is super important to being a good basketball team. And if I said there's nothing you can do about it, well, how else can we still win the game if I can't do anything about rebounding? Well, I got to make sure our offense is really good. Well, we got to make sure our defense is really good. Well, we got to make sure our free throw shooting is good. And we got to make sure we're good at getting steals. And we got to make sure there's all these other things that you need to improve to make up for this other thing that you're deficient in that you can't get any better at. Same thing with lipoprotein little a. If I know that you have a high lipoprotein little a, as of right now, I can't really do anything about it, but I know you're at higher risk for having bad outcomes. So we need to work on the other things that we can to optimize them so that this extra lipoprotein is not as big of a deal. So we need to control our cholesterol. Our blood pressure needs to be outstanding. We cannot smoke. We have to make sure our metabolic health is excellent. And that may also help people push them over the edge. Gosh, I'm kind of on the fence. Should I take this extra step with my blood pressure, my cholesterol, or whatever? I'm not sure. Oh, well, my lipoprotein little a is high. Okay, I better do it. And that's where it's really helpful. And, the European Society of Cardiology recommends every single person get it tested at least once. Our American guidelines are lagging behind. I think that will change the next time they're updated. But for me, I think everybody should get it done at least once. ApoB, you can get tested more than one time because it's a fluid marker. Lipoprotein little a is not. Yeah. So those are the two tests that, incredibly important. Everyone should get done, in my opinion, and yet no one knows. And even a lot of doctors have no idea.
Yeah.
And yet the data is there to support these things as being really, really helpful and informative as we try to assess what is our cholesterol like as it relates to our risk of heart disease.
Yeah, totally. And I think too, I think patients having this information is also so helpful because oftentimes I think patients educate us so much. If they bring up a question that we don't know about, or, bring up a clinical scenario that is new to us, like patients having that role, taking control of their health and bringing this up, like it's not only good for them, but it's good for doctors and kind of spreading the news among physicians also that these things are important.
Absolutely.
So, we're a little low on time, but maybe we can briefly talk about like what can we do, big picture, to modify cholesterol, and any take home points that you have.
Yeah, I think there's a lot of things we can do to modify our cholesterol to lower our risk. As we're going to get into in future videos, we'll talk about statins, the good, the bad, what's real, what's not. That's a whole nother important discussion that I think everyone should know about. I really do, because it's very important. And so we'll get into that in future videos. But, statins are one thing that we can do to lower it. There's non-statin medications as well. And there's also a lot of lifestyle things as well that we can get in. And so that's where it's important to, talk with your doctors, that kind of which levers you're going to pull to get your risk lowered and to lower your cholesterol. And we'll talk more in depth about those in future episodes, because that's a whole video in and of
Yeah.
itself. But then the take home points, I would just say that there are two cholesterol tests that the vast majority of the population and also a ton of doctors have no idea what they are, and they're incredibly important for giving us a true assessment of what is our cholesterol and how does that impact our risk. Not that the standard lipid panel isn't a good test. It is a good test, but these are better tests, and I think everyone deserves to have the best information so that they can make the best decisions for themselves.
So good. All right, everybody, thanks for listening. Stay tuned. We will talk all things cholesterol lowering in future videos, and we'll see you next time.